Welcome back to the second part of complication of diabetes. In this part, I will be talking about DKA and HHS, previously known as HHS, which stands for hyperosmolar syndrome, also known as the honk. DKA. In DKA, there is profound insulin deficiency. So as you know, we need insulin for the uptake of sugar into the cells. When there is a profound insulin deficiency, there is alteration of carbohydrate, protein, and fat metabolism. What happens is, when insulin is deficient, when the body does not make any more insulin, there is a state of cellular starvation, even though there is plenty of sugar in the bloodstream. These starving cells start releasing chemical messengers that go all the way to the central nervous system to inform them about this state of starvation. The body reacts by releasing a higher amount of counter-regulatory hormones, namely glucagon, cortisol, growth hormone, and catecholamines. So the release of these counter-regulatory hormones results in hyperglycemia, but still, even though the body raises the blood sugar level, the insulin deficiency does not allow the glucose to be uptaken by the cell, which results in a vicious circle. Hyperglycemia resulting in more hyperglycemia and ending up in diabetic ketoacidosis. What is the pathway? I have a diagram here. When there is an absolute deficiency of insulin, sugar is not uptaken by the cells, leading to a state of cellular starvation. The body, in an attempt to raise the blood sugar to respond to the starving cells, releases counter-regulatory hormones, namely glucagon, cortisol, growth hormone, and catecholamines. All these hormones together, they target, basically, now that we don't have, they target the liver to start the process of glycogen lysis if we have any stores, and then gluconeogenesis, which basically means creating sugars or glucose from non-glucose material. For example, one of them is the lipids. So what does the liver start doing is it start chewing up the liver, start chewing up lipids to make ketones out of it. Ketones, which are basically sugars. And the problem with these ketones is they are acid bodies. So they result in a state of ketoacidosis. So the end result is metabolic acidosis. Also, what these hormones trigger is proteolysis. What ends up happening is we use protein, we start chopping off protein to make glucose out of it. So the end up result is ketoacidosis as a result of lipid metabolism and the generation of ketones, using proteins to make glucose out of it, and then blocking the peripheral uptake of glucose by the counter-regulatory hormones, which results in hyperglycemia. When the body starts sensing hyperglycemia, especially the kidneys, it starts dumping glucose, which results in osmotic diuresis. And of course, when you're dumping the glucose into the urine, water follows, which result in dehydration. So that will take us to the next slide. So in DKA, the absolute insulin deficiency and the body's attempt to correct the state of starvation results in hyperglycemia. Hyperglycemia, of course, will lead to dehydration because of osmotic diuresis, and also using lipids to generate glucose leads to ketosis and acidosis. And of course, when we have metabolic acidosis, the body, in an attempt to equalize the abundance of hydrogen ions starts switching the hydrogen ions for potassium. So if we do a blood serum of potassium, potassium is usually low to normal, but actually at the cellular level it is low. The precipitating factor, usually it's an illness or an infection. Sometimes, and because of that, when the patient feel that they are sick, they don't take their insulin, and sometimes DKA is actually the first symptom or sign of undiagnosed diabetes. Symptoms, because of dehydration, you'll see poor skin turgor, dry mucosa, increased heart rate, postal hypertension, neuro, altered status, lethargy, weakness, GI abdominal pain, and respiratory. The most important to remember is in the body's attempt to correct metabolic acidosis, the body uses the lungs to start breathing out or exhaling excess hydrogen ions to correct the metabolic acidosis, resulting in this respiration known as Kuznets respirations. Laboratory finding, usually the blood sugar is not terribly high, over 300. I've seen a case of diabetic ketoacidosis when the patient's sugar was 240. The pH is going to be low, bicarb is going to be low, and when we check for ketones either in the body, either in serum or in urine, we'll see the presence of ketones. Serum osmolarity is going to be high. Serum K, as I mentioned, could be low, normal to high, and increased WBCs, of course, either from the illness or from the sheer stress of DKA on the body. Treatment, we basically have 3 targets. Let us remember that the reason why the body goes into DKA is because there is absolute insulin deficiency. So in order to correct that, we have to give the patient, we have to correct the acidosis. The acidosis is only going to be corrected when we start infusion of insulin. We have to lower the blood sugar slowly so as not to cause cerebral edema. Our target is usually 36 to 56 milligram per deciliter per hour. Then we have to target dehydration as well. We do this simultaneously. When the patient is admitted to the ED, we give them fluids. And of course, usually we start by NS or LR, then we do half saline, and then when the sugar is below 300, we have to give the patients some fluid that has sugar in it. Usually we do D5NS. And we correct, of course, potassium imbalance, especially potassium. As we know, with the infusion of insulin, the sugar is going to go into the cells and will drag potassium with it. So we keep a close eye on potassium levels. We usually check them Q2 hours, and then we replenish as needed. Bicarb rarely replenish until the pH is really low. Phosphates, I haven't seen them unless the level is very low. And we tend to correct magnesium and potassium together, hence they tend to go together. HHS, the mechanism is similar to DKA. The only difference is there are 2 differences. Number 1 is the patient has some insulin that prevents the body from using the lipolysis, from using lipids and the prosolipolysis to generate ketones. So the patient never goes to metabolic acidosis. That's one of the big difference. The other big difference is the hyperglycemia is severe. Usually for above 600, I have seen 12, I have seen 13. There are reported cases of 1500. There is no ketosis, as I mentioned, and because of the hyperglycemia, there is profound dehydration from osmotic diuresis, and that's what tend to kill patients. It usually happens in patients who are a little older with impaired thirst mechanism, and the neurological symptoms are pretty severe again because of the dehydration. They might come with symptoms that actually mimic seizure. And how do the labs and the precipitating factors is the same as DKA. Lab values, again, as you can expect, blood sugar is really high, no ketosis, so the pH is normal, serum osmolarity is extremely high. How do we treat? Number 1, as I said, dehydration is the big problem. Fluid replenishment, electrolyte replacement, and of course we going to need insulin infusion, and we search for the precipitating event and try to correct it. Chronic complication, really quick. We will be talking about macrovascular complication as well as microvascular. So the macrovascular, let's start with them, is basically these are complications that are concerned with large and medium-sized blood vessels, and this complication increase the risk for cardiovascular disease, namely CAD, PVD, and CVA. So in patients with diabetes, it is extremely important to control their hypertension. Microvasculature, these are very specific to diabetes. They do not appear until 10 to 20 years later. That's why early screening is extremely important, and controlling the blood sugar is a key in delaying this microvasculature complication. So the way I remember this is these complications are concerned with the tissues that do not use insulin for their uptake of glucose. I'm not going to go into the pathophysiology of it, but suffice to remember that the microvascular complication attack the nervous system, the kidneys, and the nephrons. And then the eyes. In the neuropathy, these are classified into sensory. It affects the distal distal symmetric polynephropathy. It affects the hands and the feet, and the patient tends to lose protective sensation in the lower extremities. And in some cases, patients report abnormal sensation like paresthesia, tingling, and burning. Autonomic, it affects all body systems, i.e. hypoglycemic unawareness, gastroparesis, sexual dysfunction, and so forth. This is what we use for testing for distal neuropathy. We will mention this when we talk about neurotesting. This picture shows a damaged nerve again due to the swelling, and the nerve gets damaged. Nephropathy, again, the kidney, the diabetes is a major risk factor in the development of chronic kidney disease. And what happens is the glomerular basement thickens, and then which results in glomerular sclerosis. I'll show you some pictures. The major manifestation, the early one, is you start leaking albumin, you have blood in the urine as well, and which leads to progressive kidney disease and that needs hemodialysis. These are pictures that you can see that shows the thickening. This is the normal one. This is a thickened, showing a thickened glomerular, thickened glomerulus, and then here basement membrane that is very thickened. Retinopathy, I'm not going to spend a lot of time talking about this, but I just have to mention that in diabetic retinopathy, the body starts, or the eye starts making these new blood vessels that are very thin and very friable, and they tend to bleed. I'll show you a picture right next to it. That's conclude our lectures, our part 2 of DKA and HHS. Special thanks to Mary Sullivan because I used some of her material in this lecture. Thank you, and we'll see you in another